Welcome to the deep dive. We're here to really get into the weeds of complex source material, the kind you need for true professional mastery, and boil it down into, well, pure, actionable knowledge.
That's the goal.
Today, we are tackling a really significant topic, pre-invasive and invasive carcinoma of the cervix. We've got some dense clinical sources here, packed with the kind of epidemiological and pathological detail that honestly separates general awareness from genuine expertise.
Right. And our mission today is to really master that whole scientific story, from the virus that starts it all right through to the most complex treatment options.
It's a deep dive into prevention, pathology, but also public health strategy, isn't it?
Absolutely. The science behind cervical cancer is almost like a case study. It shows how a really devastating, globally widespread cancer can be, well, functionally eliminated if you have the right public health efforts in place.
But that's the paradox, isn't it? We have the tools, scientifically speaking.
Exactly. But the burden, the actual number of women affected, remains astronomical in many parts of the world. It's a stark contrast.
Okay, let's start right there with those global numbers, because they really do set up this kind of stunning contradiction.
They do. In places with solid screening programs, developed nations, this cancer is relatively rare now.
But worldwide, still a major killer.
Third most common cancer in women, globally. And then you zoom in on areas without universal screening, and the picture changes dramatically. It becomes an immediate crisis.
Like India, which the sources highlight.
Yes, our sources are clear. In India, for instance, cervical cancer is still the most common genital cancer among women. That's not some historical fact.
It's happening now?
Right now.
Yeah.
Even with breast and ovarian cancers on the rise, cervical cancer holds that tragic top spot. And it's almost entirely down to failures in early detection. That's a systemic issue.
We need to grasp the scale here. Globally, we're looking at, what were the figures?
Around 530,000 new cases every year. And tragically, about 275,000 deaths annually.
Devastating numbers.
And the regional concentration is huge. India alone sees roughly 130,000 new cases and something like 70,000 deaths each year. Think about that impact. It means this one disease makes up about 15% of all cancers diagnosed in women across the subcontinent. 15%.
That just underscores how critical this knowledge is, implementing what we know.
It really does.
And the age profile is also sobering. This isn't primarily a disease hitting women in their later years.
No, absolutely not. It strikes women often in their most productive years. The median age at diagnosis globally is around 48.
With most cases falling between 35 and 55.
That's the main cluster, yes.
Okay.
But in these high-burden regions, like India again, the average age can skew even slightly younger. Maybe 35 to 45.
But the truly alarming statistic tied directly to that lack of screening you mentioned
is the stage at diagnosis. It's shocking. Over 75% of cases in these areas are diagnosed only when the cancer is already in advanced stages.
3/4. Presenting too late.
Exactly. And that statistic really is the core argument for why effective screening is non-negotiable. We're fighting an uphill battle from the start, because that prevention window, that early detection window, was missed.
It changes everything clinically, doesn't it?
Completely. When you diagnose at advanced stages, FIGO stage I, IB, or higher, you're looking at radical chemoradiation, high toxicity, significant long-term side effects, major impact on quality of life.
Compared to
Western countries where widespread pap smears have cut invasive cancer rates by something like 80%. And mortality down by 60%. It's proof of concept.
So the mission statement for this deep dive seems pretty clear. Cervical cancer is fundamentally a preventable disease.
It is.
And our mastery needs to zero in on understanding that crucial 10 to 15-year window, that latent period the disease gives us.
Right. And the essential tools we have, screening, prevention, to actually exploit that window effectively.
It feels like both a scientific imperative and a logistical one.
Couldn't agree more.
Okay, to really understand that window of opportunity, we need to go back to the beginning, the spark. And the science here seems, well, pretty much settled.
It is. Human Papillomavirus.
Yeah.
HPV. It's the most critical predisposing factor. It's now established as the definitive cause of cervical cancer.
The link is that strong.
Virtually 100%. If a woman develops invasive cervical cancer, you can be almost certain she had a persistent infection with a high-risk type of HPV.
But the virus doesn't usually act alone, right? There are cofactors involved.
That's crucial, yes.
Yeah.
The sources lay out a whole collection of risk factors that help determine which woman with an HPV infection actually goes on to develop cancer.
Okay, let's unpack those. Table 33.1 in our source material lists quite a few. They seem to revolve around sexual activity and maybe broader public health conditions.
That's a good summary. We see things like starting coitus before age 18. That's a
Okay.
key one because the cervix is still maturing then. It's more susceptible to the virus getting in and causing cellular changes.
Makes sense. And multiple partners.
Obvious one. Increases your exposure risk to various HPV types, including the high-risk ones. Then there's multiparity, having many children.
How does that play a role?
The exact mechanisms are complex, possibly related to hormonal changes or cervical trauma during childbirth, but it's a consistent epidemiological finding. And then factors like low socioeconomic status.
Which often connects to other things.
Exactly. It often correlates with poor access to healthcare, sanitation, maybe nutritional deficiencies. Poor personal hygiene is also listed as a contributing factor.
And the link with other STDs is explicit.
Absolutely. Having other sexually transmitted diseases, especially HIV or herpes simplex virus 2, HSV2, that seems to accelerate the process.
Why HIV in particular?
Immunosuppression. Women with HIV have a much harder time clearing the HPV virus naturally because their immune system is compromised.
Okay. And then there's smoking and drug abuse listed too.
Yes, and interestingly, these seem to be significant independent risk factors. With smoking, the thought is that carcinogenic byproducts concentrate in the cervical mucus, creating a sort of local immunosuppressive environment. Hinders the body's ability to fight off the HPV right there at the cervix.
Fascinating. There's also that historical point about male partners, the idea about smegma from uncircumcised partners being a carcinogen.
Ah, yes, that was an early hypothesis.
Yeah.
But modern epidemiology has refined that understanding.
So it wasn't the smegma itself.
Not directly, no. The observation holds true lower cancer incidence in wives of circumcised men. But the reason isn't just about smegma exposure. It's because circumcised men tend to have a lower incidence and prevalence of carrying HPV themselves.
Ah, so it reduces transmission of the virus.
Precisely. It circles back to the virus being the primary driver, not necessarily a secondary factor like smegma. It really underscores HPV's central role.
Now, this virus, HPV, it's incredibly common in sexually active adults. Yet most people don't get cancer. That difference between a transient infection and one that sticks around seems critical.
It is absolutely critical. It's really the story of the immune system doing its job, most of the time. Most sexually active women will acquire HPV at some point, often early on.
But their bodies fight it off.
In the vast majority of cases, yes. About 80 to 90% of these infections are transient, self-limited. The immune system mounts an effective response, clears the virus. Usually within about 18 months or so, it just disappears.
So if the body usually clears it, who are we most concerned about? Who needs the close monitoring?
We're really focusing on that 10 to 20% of women where the infection persists, doesn't go away.
And persistence beyond a certain age is key.
Yes. Particularly persistence of a high-risk HPV type beyond the age of 30. That becomes the single biggest clinical red flag for developing high-grade squamous intraepithelial lesions, or HSIL, down the line.
Why does persistence matter so much?
Because persistent infection allows those high-risk HPV types, 16 and 18 are the main culprits, causing about 70% of cancers to potentially integrate their viral DNA into the host's cervical cells. And when that happens, the virus can continuously express its oncogenes, proteins like E6 and E7, which basically hijack the cell's machinery. They interfere with tumor suppressor genes, drive uncontrolled cell replication, prevent cell death, essentially starting the journey towards cancer. That persistence is the trigger.
Got it. So to understand where this all happens, physically, we need to understand the transformation zone, the TZ. You hear that term constantly in cervical pathology.
You do. And if you don't understand the TZ, you can't really understand the cervical cancer screening or pathology. It's fundamental.
So break it down for us.
Okay. Start with the original squamous-columnar junction, the SCJ. That's simply the line, the border, where the two types of normal cervical epithelium meet. You've got the simple columnar epithelium lining the inside, the endocervical canal.
Glandular type cells.
Right, glandular. And then you have the tough, stratified squamous epithelium covering the outside, the ectocervix, the part you see in the vagina.
But that junction isn't static throughout life, is it?
No, exactly. Especially after puberty, with rising estrogen levels, something called everversion or colotropion happens. The softer columnar epithelium from inside the canal gets pushed outwards onto the exposed surface of the ectocervix.
And that environment is different? More acidic?
Yes, the vaginal environment is acidic, and those delicate columnar cells aren't built for it. So the body initiates a natural repair process called squamous metaplasia.
Metaplasia meaning change.
Right. The columnar cells get replaced by new, tougher, stratified squamous cells better suited to the environment. This process creates a new SCJ further out on the ectocervix.
Okay, so we have the original SCJ and the new SCJ.
And the transformation zone, the TZ, is precisely the area between the original SCJ where the junction was at birth and the new SCJ where it is now after metaplasia.
And why is that specific zone so important for cancer?
Because the cells within the TZ are undergoing active change. They're immature, rapidly dividing, undergoing this metaplastic process. This makes them uniquely vulnerable, biologically speaking, to the cancer-causing effects of a persistent high-risk HPV infection.
So that's where the trouble starts.
Almost invariably. Cervical neoplasia, both pre-invasive and invasive, overwhelmingly originates within the TZ. That's why any screening test, like a pap smear, must sample cells from the TZ, and why treatments like LATZ or ablation have to target and remove or destroy the entire TZ. Miss the TZ, you might miss the disease.
Okay, so HPV infection becomes persistent in that vulnerable transformation zone. The next step isn't immediately cancer, right? There's this pre-invasive stage. Cervical Intraepithelial Neoplasia, or CIN.
Correct. CIN describes the changes we see in the epithelium of the TZ, picked up by cytology, the pap smear, or histology from a biopsy.
What's the absolute key feature that distinguishes CIN from actual invasive cancer, pathologically speaking?
The basement membrane. In CIN, the normal stratified squamous epithelium is being replaced by these abnormal dysplastic cells. But, and this is a critical point, the underlying basement membrane remains intact.
Oh, that's the barrier.
That's the barrier. There's no invasion into the deeper connective tissue, the stroma. No stromal infiltration means it's still intraepithelial within the epithelium. It hasn't broken out yet.
Which means it's contained and theoretically easier to treat locally.
Precisely. It gives us that window for conservative, often fertility-sparing treatments. Once that basement membrane is breached, we're talking invasive cancer, a whole different ballgame.
So when pathologists look at a biopsy showing CIN, what specific cellular changes are they seeing? What defines dysplasia?
They're looking for a loss of the normal, orderly maturation of the squamous cells. Instead of nice layers, you see cellular disorganization, a disorderly arrangement. The cells themselves look abnormal, altered morphology.
Like variations in size and shape.
Yes, variation in size and shape, loss of normal polarity. They're not oriented correctly. Crucially, you see nuclear changes. The nucleus becomes too large for the cell, so the nuclear cytoplasmic ratio is altered.
And the nucleus looks different, too.
Very different. It becomes hyperchromatic stains, much darker because there's more chromatin, more genetic material. The nuclear membrane might look irregular, and you start seeing mitotic figures, signs of cell division, higher up in the epithelial layer where they shouldn't normally be, and these mitotic figures might look abnormal, atypical.
All signs that cellular control is breaking down.
Exactly. It's a progressive loss of differentiation and control.
And this process, thankfully, takes time. That leads us back to that golden window you mentioned.
The long progression timeline. This is the huge advantage we have with cervical cancer compared to many others. These precancerous lesions, CIN, typically start developing 10 to 15 years before invasive cancer emerges.
A decade or more.
Often a decade or even longer. It gives us ample time for screening to detect these changes and for intervention to prevent progression. But the urgency changes depending on the grade of CIN.
Right, let's quantify that risk. How likely is CINI, the mildest form, to progress?
Okay, looking at the progression rates is key for deciding how to manage these lesions. For CINI, which is also called mild dysplasia, the outlook is generally very good.
The body often clears it.
Very often. Spontaneous regression happens in a remarkable 80 to 90% of CINI cases. The immune system wins. Only a small fraction, maybe 1 to 4%, actually progresses to invasive cancer.
And even that takes time.
Yes. That progression, when it happens, is slow, often taking 2 to 10 years. So for CINI, especially in younger women, a watchful waiting approach with repeat screening is often perfectly appropriate.
Okay, but the picture changes quite a bit with CIN2, moderate dysplasia.
It really does. With CIN2, the clinical dynamic shifts. The chance of spontaneous regression drops significantly, maybe only 30 to 40%. About 40% might just persist as CIN2.
And the progression risk?
Critically, the risk of progression to invasive cancer jumps up to around 20%. And importantly, that progression happens much faster, typically within 1 to 5 years.
So CIN2 is where treatment starts becoming a serious consideration, not just observation.
Absolutely. It's considered a true high-risk precursor lesion.
And then there's CIN3, severe dysplasia or carcinoma in situ.
Yes. With CIN3, the game changes again. The risk of progression to invasive cancer, if left untreated, is considered very high. The sources use terms like almost all will progress.
And quickly, too.
Much more quickly, often within just 6 months to 2 years. CIN3 is not something you watch. It's something you treat definitively. It's considered essentially the immediate precursor to invasive cancer.
This progression risk explains the evolution in terminology, moving from the 3 CIN grades to the Bethesda system's LSIL and HSIL categories, which seem more focused on clinical management.
That's exactly right. The historical CIN system graded based on how much of the epithelial thickness showed dysplasia. CINI, mild dysplasia, meant the abnormal cells were confined to the lower one-third.
And the Bethesda system calls this
Low-grade squamous intraepithelial lesion, LSIL. The thinking behind LSIL is that it often reflects the transient reversible cellular changes caused by an active HPV infection, particularly in younger women, and has that high regression rate we talked about.
Okay, then the higher grades.
CIN2, moderate dysplasia, involved the lower half to two-thirds, maybe up to 75%, of the epithelium showing abnormal cells with more significant nuclear changes.
And CIN3.
CIN3 encompassed both severe dysplasia and carcinoma in situ, CIS. Here, the entire thickness of the epithelium is replaced by abnormal, undifferentiated cells. You've lost all normal layering, all stratification and cornification, but critically, still respecting that basement membrane.
Still pre-invasive. And for clinical purposes, CIN2 and CIN3 got grouped together.
Correct. The Bethesda system bundles CIN2 and CIN3 together under the single umbrella term high-grade squamous intraepithelial lesion, HSIL.
Why group them?
For clinical management, simplicity and safety. Both CIN2 and CIN3 carry a significant unacceptable risk of progression to cancer and require similar management, usually colposcopy and treatment. Grouping them as HSIL ensures that all these high-risk lesions get flagged for definitive action, reducing the chance of undertreatment or loss to follow-up if someone tried to distinguish subtle differences between CIN2 and 3 based just on cytology. HSIL means action is needed.
Makes sense clinically. Before we leave the pathology, we should mention the coilocyte. It's almost like the microscopic fingerprint of HPV itself.
Oh, the coilocyte. It's a fascinating cell. It's a squamous epithelial cell that shows specific changes due to HPV infection. The classic feature is a large, clear area around the nucleus, a paranuclear halo or vacuole. And the nucleus itself often looks wrinkled, irregular, maybe a bit enlarged and dark.
And finding these means active HPV infection?
Yes, they're considered pathognomonic diagnostic markers of productive HPV infection. You see them very commonly in LSIL, CINI, and often in biopsies from young women who've recently acquired HPV.
But they disappear as the lesion gets worse.
Interestingly, yes. As the dysplasia progresses towards HSIL, CIN2 and 3, the classic coilocytes tend to become less prominent or disappear altogether. They get replaced by the more severely atypical, undifferentiated dysplastic cells that define the high-grade lesion. So paradoxically, seeing lots of coilocytes might actually correlate with a lower-grade lesion. #tag for screening and early diagnosis modalities.
That long latent period, the identifiable precursor lesions, it makes cervical cancer almost perfectly suited for screening. And the Pap smear has been, well, one of the biggest public health wins ever.
Its impact is undeniable. Widespread cytology screening programs using the Pap smear are directly credited with that huge reduction, 80% less invasive cancer incidence, 60% less mortality in developed countries. It's a remarkably effective tool when implemented properly.
We do need to acknowledge its limitations, though. It's not foolproof. That false negative rate is a real concern.
No screening test is perfect, that's true. The Pap smear has good sensitivity for HSIL, maybe 70 to 80%, and very high specificity, 95 to 98%. But that means there's still a false negative rate of somewhere between 15 and 30%.
Meaning the test misses existing disease 15–30% of the time.
Correct. Which could be due to issues with sampling, not getting cells from the entire TZ, or the cells being obscured by blood or mucus, or even interpretation errors.
And that's why repeat screening is crucial.
Absolutely crucial. You can't rely on a single negative test. The standard protocol, historically, was if a smear is negative, you repeat it annually for 3 years. If all 3 are negative, then you might extend the interval to every 3–5 years, usually up to around age 50 or 65, depending on guidelines.
And the test performance can decline in older, postmenopausal women.
Yes, that's a key practical point. After menopause, Hormonal changes cause the SCJ, the squamous columnar junction, to often retract up into the endocervical canal.
Making it harder to sample.
Much harder to sample adequately. Plus, estrogen deficiency leads to vaginal dryness and thinning of the epithelium, called atrophy, which means fewer cells might exfoliate onto the sampling device. The smear quality can be poor.
Is there a way to improve that?
Yes, the sources mention a clinical trick. Prescribing a short course of topical estrogen cream, or sometimes low-dose oral estrogen, for about 7 to 10 days before collecting the pap smear can help.
Oh.
It helps to mature the vaginal and cervical epithelium, makes it thicker, improves exfoliation, and can sometimes help avert the SCJ slightly, making the cells easier to collect and interpret. Improves the quality of the sample.
Technology has moved on from the basic smear, though. Liquid-based cytology, or LBC, seems to be a significant improvement.
LBC is a major step up. Instead of smearing the collected cells directly onto a glass slide, the collection brush or broom is rinsed into a small vial of liquid preservative.
Okay, and then?
Back in the lab, that liquid suspension is processed. Machines can filter out a lot of the junk, the blood, mucus, inflammatory debris that can obscure the cells on a conventional smear. Then, it deposits a thin, uniform layer of cells, a monolayer, onto the slide.
So the view is much clearer for the cytotechnologist.
Exactly. It standardizes the preparation, reduces obscuring factors. Studies show it generally improves specificity, fewer false positives, and potentially sensitivity as well, leading to better detection of abnormalities.
And LBC has another big advantage, logistically.
A huge one. Because you have the cells preserved in that liquid vial, you can use the remaining sample for other tests. Most importantly, HPV DNA testing.
Ah, co-testing.
Right. You can run both the cytology and the HPV test from the same sample collection. This ability to do ancillary testing, like HPV or potentially other molecular markers in the future, is a massive benefit of LBC. Makes the whole process more efficient.
And adding that HPV DNA testing, especially for women over 30, has become pretty standard now. Why is it so valuable?
Co-testing significantly increases the overall effectiveness of screening. Adding the HPV test boosts the negative predictive value. The confidence that a negative result is truly negative up to around 95% or even higher.
So if both cytology and HPV are negative, the risk is extremely low.
Extremely low for developing significant disease in the next several years. This allows for safely extending screening intervals, maybe to 5 years for co-testing. But HPV testing is also absolutely crucial for managing those ambiguous cytology results.
You mean SUS, atypical squamous cells of undetermined significance? That sounds vague.
It is vague. SUS is one of the most common abnormal pap results. It means the cytologist sees cells that are slightly abnormal but not definitively LSIL or HSIL. They're just atypical. It creates a clinical dilemma. Is this something minor or is it hiding a more serious lesion?
How does HPV testing help sort that out?
It's the perfect triage tool. If a woman has an ASCUS result, you test her sample for high-risk HPV DNA. If she's positive for high-risk HPV, her risk of having an underlying HSIL, CIN2 or 3, is significant, maybe 10–20%. So she needs to go directly to colposcopy for a closer look.
And if she's ASCUS but HPV negative?
Then the likelihood that the ASCO-CS finding represents a significant precancerous lesion is very, very low, probably less than 1%. So she can usually just be managed with repeat screening in a year or so. HPV testing effectively sorts the high-risk ASCUS from the low-risk ASCUS, resolves that ambiguity.
We should also mention automated screening.
Right. Some labs use computerized image processors. These systems can rapidly scan slides and automatically identify those that are highly likely to be completely negative.
Filtering them out.
Exactly. It can potentially eliminate, say, 25% of the clearly negative smears from needing manual review by a cytotechnician. This allows the human experts to focus their time and attention on the slides that are more likely to contain abnormalities. Improves efficiency and potentially accuracy by reducing fatigue.
Okay, but all this cytology, LBC, HPV testing, it requires infrastructure, labs, trained personnel. What about low-resource settings where that's just not available?
That's a critical question. And this is where visual inspection techniques become vital alternatives. The main one is VIA visual inspection with acetic acid.
Acetic acid, like vinegar.
Pretty much.
Yeah.
A dilute solution, usually 3 to 5% acetic acid, is applied to the cervix. You wait about a minute, and then you look, maybe with just a bright light, sometimes with slight magnification.
What are you looking for?
Abnormal areas, particularly precancerous lesions, tend to turn white acetowhite. The acetic acid causes dehydration and coagulation of intracellular proteins, which are more abundant in rapidly dividing abnormal cells with larger nuclei. Normal squamous epithelium usually doesn't change much or turns only faintly white.
How reliable is VIA?
It's highly sensitive, meaning it's good at picking up potentially abnormal areas. Its false negative rate for detecting underlying high-grade disease is actually very low, though sources mention around 0.9%. So it's
That
unlikely to miss a significant lesion. But its specificity is quite low. It has a high false positive rate. Lots of benign things, inflammation, immature metaplasia, can also turn acetowhite. So you end up investigating or treating more women than might strictly be necessary. But in a low-resource setting, high sensitivity is often prioritized to avoid missing cancers.
And there's a similar technique using iodine.
Yes, visual inspection with Lugol's iodine. Lugol's iodine stains glycogen. Normal, mature squamous epithelium is rich in glycogen, so it stains a dark mahogany brown color.
And abnormal cells.
The abnormal cells, dysplastic cells, and cancer cells have very little or no glycogen, so they don't take up the stain. They remain unstained, appearing as pale yellow or mustard-colored areas against the dark brown background. Sharp, well-defined, thick, unstained areas are highly suspicious.
These visual methods, VIA and VILI, are often used in a specific strategy called see and treat. What's that about?
See and treat is a pragmatic public health approach designed specifically for settings where getting women to come back for follow-up appointments is difficult.
Because of distance, cost, other barriers.
Exactly. Loss to follow-up is a massive problem that undermines screening programs. So with see and treat, if a woman has a positive VIA or VILI test, meaning a suspicious lesion, is seen, she is offered treatment immediately in the same visit.
Treatment usually being?
Usually cryotherapy, freezing, or sometimes thermal ablation, cautery, which are relatively simple, low-cost procedures that can be done in a basic clinic setting.
The advantage is obvious. You guarantee treatment for potentially high-risk women.
Right. You eliminate that risk of them being lost before treatment.
But the disadvantage must be over-treatment.
That's the trade-off, yes.
Mm.
Because VIA have low specificity, you will inevitably end up treating some women whose lesions might have been benign or might have regressed on their own. But the public health calculation is that the benefit of preventing invasive cancers in the women who do have high-grade lesions outweighs the risks and costs of overtreating some with low-grade or benign changes. It's considered cost-effective and life-saving in many contexts.
Okay, so whether it's an abnormal PAP, positive HPV, or positive VIA-VILI, the next step, if further investigation is needed, is usually colposcopy and biopsy.
Correct. The pap smear, or VIA-VILI, flags abnormal cells or suspicious areas. Colposcopy is the tool used to locate the exact source of those abnormal cells and characterize the lesion.
It was basically a microscope for looking at the cervix?
Essentially, yes. A colposcope is a binocular microscope with a bright light source that provides magnified, stereoscopic views of the cervix, vagina, and vulva. After applying acetic acid, and sometimes Lugol's iodine, the clinician carefully examines the transformation zone.
Looking for those acetowhite changes, abnormal blood vessel patterns.
Exactly. Looking for specific features like the intensity and margins of acetowhite areas, abnormal vascular patterns called mosaicism or punctuation, the overall size and location of lesions. Colposcopy guides the clinician to the most abnormal-looking areas to take biopsies from.
And determines the type of biopsy needed. Punch versus cone.
Precisely. If there's a well-defined, visible lesion on the ectocervix, a small punch biopsy taken directly from the most suspicious spot might be sufficient. You might take multiple punch biopsies.
But sometimes you need more tissue, or the lesion goes up into the canal. That's when a cone biopsy comes in.
Right. A cone biopsy is a more extensive procedure. It excises a cone-shaped piece of tissue that includes the entire transformation zone, the suspicious lesion, and a portion of the endocervical canal.
When is that necessary?
It's needed if the lesion is large. If the upper limit of the lesion or the entire SCJ cannot be fully visualized with a colposcope, meaning disease might be hiding up in the canal, if cytology suggests a high-grade lesion, HSIL, or glandular abnormality, but colposcopy doesn't show a clear source, or if there's a significant discrepancy between the pap smear result and the colposcopy findings.
So it's both diagnostic and potentially therapeutic.
Yes, a cone biopsy serves both purposes. It provides a larger tissue sample for the pathologist to make a definitive diagnosis and, importantly, to rule out invasive cancer. And if the margins of the cone are free of disease, it can sometimes serve as the complete treatment for CIN.
Traditionally, cone biopsies were done with the scalpel, the cold knife cone, often under general anesthesia.
That was the classic method. Still used sometimes, especially if a very precise or deep cone is needed. But it involves general anesthesia, hospitalization, and higher risks of bleeding.
So the preference has shifted.
Largely, yes. The more common excisional procedure now is LOETZ, which stands for Large Loop Excision of the Transformation Zone, or LEEP, Loop Electrosurgical Excision Procedure, basically the same thing.
How does LETZ work?
It uses a thin wire loop electrode connected to an electrosurgical unit. Low voltage, high frequency current passes through the loop, allowing it to cut through the tissue like a hot knife through butter, while simultaneously coagulating blood vessels to minimize bleeding. It excises the transformation zone, similar to a cone, but it's usually done under local anesthesia in an outpatient clinic setting.
Why has LAZAC become so popular?
Several reasons. It's much simpler and quicker to perform than a cold knife cone, less bleeding, quicker recovery time for the patient. Generally done under local, avoiding the risks of general anesthesia, and it still provides that crucial tissue specimen for histological examination. It's effective, efficient, and generally well tolerated. Tag V. Treatment of pre-invasive lesions, CIN/HSIL, in detail.
Okay, moving into treating confirmed pre-invasive disease, CIN or HSIL, the sources emphasize one absolute prerequisite before you destroy or remove any tissue.
Non-negotiable. Before any treatment for dysplasia or CIN, you must have a colposcopically directed biopsy confirming the diagnosis and, crucially, ruling out underlying invasive cancer.
You can't treat based just on a Pap smear result alone.
Absolutely not, especially if the smear suggests HSIL. There's always a risk, maybe small but real, that an abnormal Pap is reflecting an underlying microinvasive or even, frankly, invasive cancer that wasn't fully sampled. Treating without histological confirmation could lead to disastrous undertreatment of an early cancer. So colposcopy and biopsy first, always.
Once microinvasion is ruled out, we have two main approaches. Conservative destructive methods, also called ablative.
Right, ablation. These methods destroy the abnormal tissue in situ, but they don't provide a specimen for further analysis.
Like cryosurgery.
Cryosurgery is a classic example. It's generally cheap, effective for well-selected lesions, and often done as an outpatient procedure without needing anesthesia, maybe just mild cramping. It uses a probe cooled by a cryogen, typically nitrous oxide these days, which gets colder than the older CO2 units.
How does freezing kill the cells?
The intense cold forms ice crystals inside and outside the cells, disrupting cell membranes and organelles. The subsequent thawing also causes damage. It creates a zone of necrosis that includes the abnormal epithelium.
What are the downsides of cryo?
Two main ones. First, patients get a pretty significant watery vaginal discharge for a week or two afterwards as the necrotic tissue slows off. It can be quite bothersome.
And the second, more significant clinically.
Yes, the freezing and subsequent healing process often causes scarring that leads to indrawing of the squamocolumnar junction, SCJ. The SCJ gets pulled up higher into the endocervical canal.
Why is that a problem?
It makes future surveillance much harder. If the SCJ and the entire transformation zone aren't fully visible on follow-up colposcopy, you can't be certain that disease hasn't recurred or persisted higher up in the canal. It compromises future assessment.
Okay, what's the other main ablative method?
Laser ablation. Laser ablation, usually using a text CO2 laser. This is also typically an outpatient procedure, but it's more expensive, requires specialized equipment and training, and usually needs local anesthesia because it involves vaporization of tissue, which can be painful.
What are the advantages of laser over cryo?
It's very precise. The laser vaporizes the tissue layer by layer, allowing for accurate depth control. There's minimal bleeding because the laser seals small blood vessels as it cuts. Less post-procedure discharge than cryo. But the biggest advantage...
So does it affect the SCJ?
Critically, it does not cause significant indrawing of the SCJ. Healing after laser ablation tends to preserve the cervical anatomy much better. This is a huge plus for future follow-up and colposcopic assessment. If repeat treatment is ever needed, the anatomy is usually preserved.
So ablation destroys tissue. The alternative is excision, which removes it.
Right, the conservative excisional methods. We already talked about Elliott sleep and cold knife conization.
And the key advantage of excision is...
You get a tissue specimen. The pathologist can examine the entire excised piece, confirm the diagnosis, assess the margins to see if the lesion was completely removed, and definitively rule out any hidden microinvasive or invasive disease. That histological confirmation is invaluable.
Elite sleep seems to be the preferred excisional method now.
It really is, for most cases. It has a very high cure rate for HSIL, around 90 to 95%. It balances the need for a histological specimen with the advantages of being an outpatient procedure under local anesthesia with relatively low cost and good safety profile.
But these excisional procedures, LATZ and cone, aren't without potential downsides, especially for women who still want to have children.
That's a very important consideration. Removing a significant chunk of cervical tissue, especially the deeper stromal tissue removed in a cone or a deep LAETZ, can have long-term consequences for future pregnancies.
What kind of complication?
Immediate risks are bleeding and infection. Longer term, you can get cervical stenosis, a narrowing or scarring of the cervical canal, which could potentially interfere with menstruation or fertility. But the biggest concern is cervical incompetence.
Meaning the cervix isn't strong enough to hold a pregnancy?
Exactly. Removing that supportive tissue can weaken the cervix, increasing the risk of miscarriage in the second trimester, or more commonly, preterm labor and delivery in subsequent pregnancies. The risk seems proportional to the amount of tissue removed, especially the height of the cone or loop specimen.
So this risk must heavily influence the choice between ablation and excision for a young woman planning a family.
Absolutely. It's a major part of the counseling. If you have a young woman who desires future pregnancies, and she has a confirmed HSIL lesion that is fully visualized, small, and appears suitable for ablation, meaning the risk of hidden invasion seems very low, then an ablative procedure, especially laser ablation because it preserves the SCJ anatomy, might be preferred to minimize the risk to future pregnancies.
Even though you lose the histology specimen from ablation.
It's a calculated risk, a trade-off. You prioritize preserving cervical integrity for future pregnancies over the absolute certainty provided by an excisional specimen in carefully selected cases. However, if the lesion is large, extends into the canal, the SCJ isn't fully seen, or there's any suspicion of invasion, then the priority has to shift back to excision, usually L-Adzeal, to get that definitive histology, despite the potential impact on future pregnancies. Patient safety comes first.
Finally, what about hysterectomy for just pre-invasive disease, for HSIL? Has that ever done?
Generally, doing a hysterectomy just for CIN or HSIL is considered overtreatment. These lesions can almost always be managed effectively with conservative methods.
But there are exceptions.
There are specific indications where hysterectomy might be considered. For example, in an older woman who has completed her family and perhaps has other gynecological issues like fibroids or heavy bleeding that might warrant a hysterectomy anyway.
Or if conservative treatment fails.
Yes, if HSIL persists or recurs after one or maybe two conservative treatments, or if the patient is considered unreliable for the necessary long-term follow-up after conservative therapy. Or, very importantly, if microinvasion, stage IA1, is found on the cone or LLETZ specimen, sometimes a hysterectomy is recommended to ensure complete removal. But for uncomplicated HSIL in a woman who wants conservative management, hysterectomy is usually not the first choice.
All right, now we crossed that critical line. The basement membrane has been breached. We're dealing with invasive cervical cancer. And those incidence rates you mentioned earlier really highlight the impact when screening fails or isn't available.
The disparity is stark, yes. In developed countries with strong screening, maybe 8 cases per 100,000 women. In high-burden areas like India, it jumps to 20 to 35 per 100,000 women, particularly in that 35 to 65 age group.
And pathologically, most of these are squamous cell carcinoma.
About 95% are SCC. Usually the non-keratinizing type is more common than the keratinizing type.
But there's that other 5% adenocarcinoma. You mentioned its incidence might be rising.
Yes, adenocarcinoma makes up the remaining 5% or so. And there's evidence its relative proportion has been increasing, particularly in younger women. There's a suggested link, though not definitively proven for all cases, with long-term use of combined oral contraceptive pills, which might influence the glandular epithelium where adenocarcinoma arises.
And adenocarcinoma presents some unique challenges.
It does. Because it arises from the glandular cells inside the endocervical canal, the lesion itself can be hidden from view during colposcopy and might not shed cells as readily for a pap smear. Diagnosis can be delayed.
Okay, once cancer becomes invasive, how does it spread?
It spreads in predictable ways. First, direct local extension. It grows outwards into the surrounding tissues, the vaginal walls, upper part first, the perimetrium.
The perimetrium being the connective tissue beside the cervix.
Exactly, the tissue that contains the uterine blood vessels and ureters, extending out towards the pelvic side walls. It can also grow directly forwards into the bladder or backwards into the rectum in later stages.
And then lymphatic spread.
Yes, that's the next major route. It follows the lymphatic drainage pathways. First stop is usually the pelvic lymph nodes, the perimetrial nodes, the obturator nodes and the obturator fossa, the internal iliac, hypogastric, and external iliac nodes along the pelvic blood vessels. And from there, from the pelvic nodes, it can spread upwards to the common iliac nodes and then, crucially, to the periaortic lymph nodes, which run alongside the aorta in the abdomen. Periaortic spread is considered distant metastasis for treatment planning purposes.
Does the risk of lymph node spread increase significantly with the stage of the cancer?
Dramatically. For the very earliest microinvasive stage, IA1, the risk is less than 1%. For IA2, it might be 2 to 7%, but by stage IB, it's maybe 15–20%, stage 2, maybe 25–35%, stage 3, 40–50%. And stage 4, the risk of pelican and/or periaortic node involvement is very high, 40 to 65% or more. Nodal status is a critical prognostic factor.
And what about spread to the ovaries? Is that common?
This depends heavily on the histology. For squamous cell carcinoma, ovarian metastasis is actually quite rare, only about 1% of cases.
But for adenocarcinoma?
Much higher risk. Around 10% of cervical adenocarcinomas will have metastasis to the ovaries. This difference has major implications for surgery, especially the decision about whether to remove the ovaries, oophorectomy, at the time of hysterectomy, particularly in premenopausal women. For SCC, ovarian preservation is usually safe. For adenocarcinoma, removal is often recommended.
Treatment for invasive cancer is guided by staging. The FIGO system is standard. Our sources stress that FIGO staging is primarily clinical. Why is that emphasized?
The FIGO International Federation of Gynecology and Obstetrics staging system, the 2009 version referenced here, was designed to be applicable worldwide, including in low-resource settings where advanced imaging might not be available. Therefore, the stage is determined primarily by clinical examination, meaning a thorough pelvic exam, speculum exam, bimanual vaginal exam, and importantly, a rectovaginal exam to assess the parametria and uterosacral ligaments, plus basic investigations like a chest X-ray to check for lung mets, and sometimes an IVP, intravenous pyelogram, and X-ray using dye to check if the ureters are blocked by tumor.
So it's based on tumor size and how far it seems to have spread based on what the clinician can feel and see with basic tools.
Exactly. For example, stage 1 is confined to the cervix. Stage 2 means it spread beyond the cervix, but not to the pelvic wall or lower vagina. IIA, no parametrial involvement. IEB involves parametrium. Stage 3 reaches the pelvic wall or lower vagina or causes kidney blockage. IAA, lower vagina. IIB, pelvic wall or hydronephrosis. Stage 4 is spread to bladder-rectum mucosa. IVA or distant mets, IVB.
And there's one specific clinical finding that automatically bumps the stage up significantly.
Yes. If the clinical exam or basic imaging, like ultrasound or IVP, reveals hydronephrosis swelling of the kidney because the ureter is blocked by tumor, that automatically makes it stage IIAB regardless of other findings, because it implies the tumor has reached the pelvic sidewall where the ureter runs.
Nowadays, though, we routinely use advanced imaging like CT and MRI. How do they fit in? Do they change the official FIGO stage?
This is a really important point the sources make.
Yeah.
CT and MRI are invaluable tools for treatment planning. They give much more detailed anatomical information. CT is good for detecting enlarged lymph nodes. Usually 1 centimeter is considered suspicious. MRI is actually superior to CT and even clinical exam for assessing the extent of local tumor spread, particularly subtle parametrial infiltration, which determines the difference between stage I by IA and stage IIB.
But the results don't change the official clinical stage assigned.
Correct. According to the FIGO rules, at least up to the 2009 staging, the findings from advanced imaging like CT or MRI should not be used to change the clinically determined stage.
Why not? Seems counterintuitive.
The rationale is to maintain consistency and comparability of staging and outcome data across different centers and different eras, regardless of the available technology. If you allow advanced imaging to upstage patients, detecting disease clinical exam missed, it creates stage migration. Patients previously staged lower would now be staged higher, artificially improving survival stats for lower stages and worsening them for higher stages, making comparisons impossible. So imaging informs treatment, but doesn't alter the fundamental FIGO stage.
What about PCT scans? They seem to be used frequently now.
FDG-PTT is now considered the most sensitive imaging modality, the gold standard for overall assessment, especially for nodal staging and detecting distant metastasis or recurrence.
How does PQ work?
It uses a radioactive tracer, F18-fluorodeoxyglucose, FDG, which is basically radioactive sugar. Cancer cells are metabolically hyperactive. They consume much more glucose than normal cells. So the FDG tracer accumulates in cancerous areas, which then light up on the PTT scan. Combining PT functional data with CT anatomical data gives a very accurate map of metabolically active disease.
Is it better than CT-MRI for lymph nodes?
Generally, yes. PTCT is superior for detecting metastatic involvement in lymph nodes, even nodes that aren't significantly enlarged on CT-MRI. It's particularly valuable for assessing the periaortic nodes, which are harder to assess clinically. It's also excellent for detecting unsuspected distant metastases and for identifying recurrence after treatment. But again, even PT-CT findings technically shouldn't change the initial clinical FIGO stage, though they heavily influence treatment decisions.
Okay, let's walk through treatment based on that FIGO stage, starting with the very earliest invasive stages. Stage IA1.
Stage IA1 is defined by microscopic invasion, diagnosed only on biopsy or cone, with stromal invasion less than 3 millimeters deep and 7 millimeters wide, and crucially, no lymphovascular space invasion, LVSI. The risk of lymph node metastasis here is extremely low, less than 1%.
So treatment can be quite conservative.
Yes. For women desiring fertility preservation, a therapeutic condensation, cone biopsy, with clear margins is often sufficient treatment. For women who have completed childbearing, a simple extrafascial hysterectomy, type I hysterectomy, just removing the uterus and cervix, is adequate. Lymph node dissection is generally not required for IA1 unless LVSI is present on the cone specimen.
What about stage IA2, slightly more invasion?
Stage IA2 has invasion between 3 millimeters and 5 millimeters deep, still less than 7 millimeters wide. Here, the risk of lymph node involvement creeps up, maybe 2 to 7%, so treatment needs to be more expensive.
Meaning a bigger hysterectomy and checking the nodes?
Right. The standard is usually a modified radical hysterectomy, type 2 hysterectomy, which removes a bit more tissue around the cervix, the medial parametria, combined with pelvic lymph node dissection or sampling.
Is fertility preservation still an option for IA2? Or maybe the very small IB1?
Yes. For carefully selected young women with stage IA2 or small stage IB1 tumors, usually defined as less than 2 centimeters, who strongly desire future fertility, there's a specialized procedure called radical vaginal trachelectomy, often called the Dargent procedure.
Trachelectomy means removing the cervix.
Exactly. The procedure removes the entire cervix, the upper part of the vagina, and the surrounding parametrial tissue, but it leaves the main body of the uterus, the fundus, intact. The uterus is then reattached to the remaining vagina, often with a permanent stitch, cerclage, placed around the new opening to provide support.
And the lymph nodes.
It's always combined with a separate laparoscopic pelvic lymphadenectomy to check the nodes. If the nodes are negative, the uterus is preserved. It's a complex surgery, requires specialized expertise, and is only suitable if the tumor is small, 2 centimeters, and confined to the cervix. But it can allow successful pregnancy afterwards, although with a higher risk of preterm birth.
Okay, now for the bulk of early-stage invasive cancers. Stages IB and IIA. These are tumors clinically confined to the cervix, IB, or spreading slightly to the upper vagina but not the parametrium, IIA. Here, there seems to be a fundamental choice in treatment.
Yes, for stages IB and IIA, there are generally 2 primary curative treatment options with very similar long-term survival rates, often around 80–90% 5-year survival. The choice is between radical hysterectomy with pelvic lymphadenectomy surgery or primary chemoradiation, radiation therapy combined with chemotherapy.
Let's compare those head-to-head. What's the surgery involved?
The standard surgery is the radical hysterectomy, also known as the Wertheim's hysterectomy or type 3 hysterectomy. This is a much more extensive operation than a simple hysterectomy.
What exactly gets removed?
It involves removing the entire uterus and cervix, the parametrial tissues all the way out to the pelvic side walls, the uterosacral ligaments, and the upper 1 to 2 centimeters of the vagina. Plus, a full bilateral pelvic lymph node dissection is mandatory.
And the alternative is chemoradiation.
Yes, primary chemoradiation. This involves external beam radiation therapy, EBRT, delivered to the whole pelvis over several weeks, combined with intracavitary radiation, brachytherapy, where radioactive sources are placed directly into the cervix and uterus for a high-dose boost. And crucially, this radiation is given concurrently with low-dose chemotherapy, usually weekly cisplatin.
Why add the chemo?
Cisplatin acts as a radiosensitizer. It makes the cancer cells more susceptible to being killed by the radiation, significantly improving the effectiveness of the radiotherapy and boosting survival rates compared to radiation alone. Concurrent chemoradiation is the standard.
So if survival rates are similar between radical surgery and chemoradiation for these stages, how do patients and doctors choose? It must come down to side effects and a quality of life trade-offs.
Exactly. It's a complex decision based on patient age, fitness for surgery, tumor characteristics, patient preference, and potential long-term side effects.
What are the main advantages of choosing surgery?
Surgery offers potentially better preservation of ovarian function in premenopausal women. The ovaries can often be left in place, if histology is SCC, or sometimes moved out of the radiation field, ovarian transposition, before radiation might be needed post-op. Surgery provides precise pathological staging information from the removed tissues and nodes, which can guide further treatment if needed. And importantly, surgery generally results in better long-term vaginal function, less scarring, dryness, and shortening compared to radiation, which can significantly impact sexual health.
But surgery has its own risks and downsides.
Definitely. Radical hysterectomy is major surgery. There's a small but real risk of operative mortality, around 1%. There are significant risks of immediate complications like bleeding, infection, injury to the bladder or ureters or rectum, leading to fistulas. And long-term, many women experience some degree of bladder dysfunction, difficulty emptying, incontinence, or bowel issues.
Okay, now the pros and cons of primary chemoradiation.
The main advantage of radiation is that it's applicable to almost all patients, including those who are medically unfit for major surgery. It avoids the immediate risks of surgical mortality and major complications like fistulas.
But the long-term side effects of radiation can be significant and irreversible.
Yes, radiation inevitably destroys ovarian function, causing premature menopause in younger women unless the ovaries were transposed beforehand. It causes significant vaginal fibrosis, stenosis, narrowing, and dryness, which can make intercourse difficult or impossible. There can be chronic radiation cystitis, bladder inflammation, or proctitis, rectal inflammation, causing long-term urinary or bowel symptoms. And there's a small but real long-term risk of developing radiation-induced secondary cancers like sarcomas in the treated area years later.
So for a young, otherwise healthy woman with stage IBIA cancer, the tendency might lean towards surgery if feasible to preserve ovaries and vaginal function.
Generally, yes. If the patient is a good surgical candidate, primary surgery is often preferred for younger women to avoid premature menopause and maintain better sexual function, accepting the risks of surgery itself. For older women, or those with significant medical comorbidities making surgery risky, primary chemoradiation might be the better choice. It's a very individualized decision.
What about the more locally advanced stages, stage IIB3 IVA, where the cancer has clearly spread beyond the cervix into surrounding tissues or pelvic wall?
Once the cancer has definitely invaded the perimetrium, stage IB, reached the pelvic sidewall or lower vagina or caused hydronephrosis, stage 3, or invaded the bladderectal mucosa, stage IV, radical surgery is no longer considered a curative option as the primary treatment. The disease is too extensive to be completely removed surgically with clean margins.
So for these advanced stages, chemoradiation becomes the standard.
Yes. Concurrent chemoradiation with cisplatin is the established primary standard of care for locally advanced cervical cancer, stages IIB through IVA. The goal is cure, and chemoradiation offers the best chance, although cure rates are lower than for early-stage disease. Surgery might occasionally play a role after radiation in specific circumstances, like for residual disease.
Okay.
But primary treatment is chemoradiation. #TAG7, special clinical scenarios and prevention.
Let's touch on a few particularly complex situations. First, cancer diagnosed during pregnancy. That must add layers of difficulty.
It's incredibly challenging, thankfully relatively rare. Diagnosis itself is tricky. You want to confirm invasive cancer, but minimize risks to the pregnancy.
So a full cone biopsy is usually out.
Generally avoided during pregnancy due to the very high risk of hemorrhage and potentially causing miscarriage or preterm labor. Instead, diagnosis relies on careful colposcopy and multiple targeted punch biopsies for the most suspicious areas. Staging also needs care.
What imaging is safe?
MRI is considered safe during pregnancy and is the preferred imaging modality for assessing tumor size and local spread. CT scans, due to radiation exposure to the fetus, are contraindicated.
And treatment depends heavily on how far along the pregnancy is.
Entirely. It hinges on gestational age and fetal viability. If invasive cancer, say stage IB or IIA, is diagnosed early in pregnancy, before fetal viability, typically considered around 20-24 weeks, the options are stark and ethically complex.
Like terminating the pregnancy.
Yes. One option is termination of the pregnancy followed immediately by standard treatment for the cancer stage, radical hysterectomy or chemoradiation. Alternatively, some protocols might allow for immediate radical surgery, Wertheims, with the fetus in situ, essentially sacrificing the pregnancy to treat the mother's cancer promptly. A third, more controversial option in very specific early cases might be neoadjuvant chemotherapy during pregnancy, followed by later delivery and treatment, but that's complex.
What if the diagnosis happens later in pregnancy, closer to term?
If the diagnosis is made after the fetus is potentially viable, say 24 weeks, the usual approach is expectant management. Delay definitive cancer treatment briefly to allow the fetus to mature further, often aiming for delivery around 32-34 weeks after giving steroids for fetal lung maturity.
And delivery itself.
Delivery must be via classical cesarean section. A low transverse incision is avoided because you don't want to cut through the potentially cancerous cervix. Immediately following the C-section, the definitive cancer treatment, usually radical hysterectomy or starting chemoradiation, is performed, essentially treating the patient as if she weren't pregnant anymore.
A really difficult scenario. Let's also revisit endocervical adenocarcinoma quickly. You mentioned it's often in younger women and harder to detect.
Yes, adenocarcinoma arises from the glandular cells lining the endocervical canal, higher up than where SCC usually starts in the TZ. This means the lesion can be easily missed by a standard pap smear, which samples the ectocervix and lower canal. It might not be visible on colposcopy if it's entirely within the canal.
So diagnosis might require more specific sampling.
Often, yes. Diagnosis might require a dedicated endocervical curettage, ECC, scraping the inside of the canal, or even a diagnostic cone biopsy to find the lesion.
And treatment needs to be aggressive, especially regarding the ovaries.
Treatment generally follows similar principles as SCC based on stage, often involving chemoradiation plus mass surgery. However, because of that significantly higher risk of ovarian metastasis, around 10% for adeno versus 1% for SCC, bilateral salpingo-oophorectomy, removal of tubes and ovaries, is usually recommended as part of the surgical management for invasive adenocarcinoma, even in premenopausal women. Ovarian preservation is generally not advised.
What about when cancer comes back? Recurrence management. Most happen within the first few years.
Yes. The majority of recurrences, if they're going to happen, occur within the first 2 to 5 years after primary treatment. Follow-up is most intensive during this period.
How are recurrences treated? Depends where it comes back.
Exactly. Treatment depends on the location of the recurrence and what the primary treatment was. If the recurrence is central, in the cervix vagina, after previous primary radiation therapy, then surgery might be an option. Sometimes a hysterectomy, if feasible. But for central recurrence after radiation, the main salvage surgical option is the pelvic exoneration.
That sounds extensive.
It is arguably the most radical pelvic surgery performed. It's reserved for highly selected patients with recurrent cancer confined to the central pelvis, with no spread to the pelvic sidewalls or distant sites.
What does it involve removing?
Depending on where the recurrence is. An anterior exoneration removes the uterus, cervix, vagina, bladder, and urethra, requiring creation of a urinary diversion, like an idle conduit. A posterior exoneration removes uterus, cervix, vagina, and rectum, requiring a colostomy. A total exoneration removes all of those structures.
Massive impact on quality of life.
Huge. But for carefully selected patients with isolated central recurrence after radiation, it can offer a chance of long-term survival, maybe 50–60%, 5-year survival in some series. But the morbidity is high.
The selection criteria must be incredibly strict.
Extremely strict. It's generally contraindicated in elderly patients, maybe 80, if the tumor is fixed to the pelvic sidewall, meaning it can't be completely removed, or if there's any evidence of lymph node involvement outside the central pelvis or distant metastasis. It's a salvage procedure of last resort for potentially curable central recurrence.
Okay, let's end on a much more positive note. Prophylaxis and prevention. We actually have the tools to stop this disease before it starts.
We absolutely do. Prevention has multiple levels. At a basic public health level, promoting barrier contraception, condoms, helps reduce the transmission of HPV and other STIs that are cofactors.
But the real game changer is the vaccine.
The prophylactic HPV vaccine is a true triumph of medical science. These are not therapeutic vaccines. They don't treat existing infection or disease. They are prophylactic. They prevent infection from happening in the first place.
Like Gardasil 9 mentioned in the sources, how does it work?
HPV vaccines are typically made from virus-like particles, VLPs. These are engineered proteins that mimic the outer shell of the HPV virus but contain no actual viral DNA, so they cannot cause infection. They trick the body into thinking it's seen the real virus.
Triggering an immune response.
Exactly. They trigger a very strong immune response, generating high levels of protective neutralizing antibodies. These antibodies circulate in the body and are present at the cervix. If the person is later exposed to the actual HPV types covered by the vaccine, these antibodies bind to the virus and prevent it from infecting the cervical cells.
And Gardasil 9 covers 9 types.
Yes, it's non-valent. It covers HPV types 6 and 11, which cause about 90% of genital warts. And crucially, it covers 7 high-risk oncogenic types, 16, 18, the 2 main ones causing 70% of cancers, plus 31, 33, 45, 52, and 58.
So collectively, those 7 types account for.
Together, those 7 high-risk types account for approximately 90% of all cervical cancers worldwide. So the vaccine has the potential to prevent the vast majority of cases.
Who should get the vaccine and when?
The key is that it must be given before exposure to the virus. That means ideally given to adolescents, both girls and boys, before they become sexually active. The target age is typically around 11, 12 years old, although it can be given earlier or later as catch-up vaccination.
My boys, too.
Vaccinating boys helps protect them from HPV-related cancers, like anal, penile, or pharyngeal cancers, and genital warts. And it also contributes significantly to herd immunity, reducing the overall circulation of HPV in the population, which further protects unvaccinated females.
And if someone gets the vaccine before exposure, do they still need screening later?
That's the current recommendation, yes. While the vaccine is highly effective against the targeted types, it doesn't cover all oncogenic types, so there's still a small residual risk. Also, vaccine uptake isn't universal, and some women may not have received it or completed the series. So screening, likely with modifications like less frequent intervals or starting later, will probably still be necessary for the foreseeable future, even in vaccinated populations. But the vaccine is the cornerstone of primary prevention.
And if someone is vaccinated preemptively, no need to test them for HPV first.
Correct.
Yeah.
There's no clinical utility in testing for HPV before giving the prophylactic vaccine in the target adolescent age group. The goal is prevention before exposure. #ACHECK Stambro conclusion. Final takeaways.
So wrapping this deep dive up, it's clear cervical carcinoma is fundamentally driven by persistent infection with high-risk HPV.
Absolutely. And it typically strikes women during their prime reproductive and productive years.
But the crucial takeaway is that long pre-invasive period, that 10 to 15-year window where CIN develops before cancer, that's our opportunity.
It is. And we've seen the mastery involved in leveraging that window. Effective screening, whether traditional pap smears, LBC, HPV, co-testing, or even via villi in resource-limited settings, allows us to detect these precursor lesions.
And colposcopy with biopsy is key to confirming the diagnosis and ruling out invasion.
Precisely. That combination allows us to pick up over 90% of pre-invasive lesions effectively.
And then we have tailored treatment options, conservative ablation like laser, balancing efficacy with fertility preservation.
Or excisional methods like LET sleep, providing that essential histology specimen to ensure microinvasion isn't missed, while still often being fertility sparing compared to older methods.
We have precise tools, adaptable to the patient's age, lesion characteristics, and future reproductive desires.
And even when faced with invasive cancer, the structured approach using FIGO clinical staging, informed by advanced imaging, helps guide the choice between radical surgery, often preferred for younger, fit women with early disease, and highly effective concurrent chemoradiation, the standard for locally advanced disease or poor surgical candidates.
The trade-offs between surgery and radiation are significant, focusing heavily on long-term quality of life, ovarian function, and sexual health.
Requires careful, individualized counseling.
But when you synthesize everything we've discussed, the clear viral cause, the long latent period, the effective screening methods, and, critically, the existence of a prophylactic vaccine that prevents 90% of cases, it really forces you to confront the global public health reality.
We genuinely have the scientific knowledge and tools to potentially eradicate or at least virtually eliminate this disease as a major public health problem.
Which brings us to our final provocative thought for you, our listener, to mull over.
Knowing that cervical cancer is almost entirely preventable through adolescent vaccination before HPV exposure, and given the proven high efficacy of vaccines like Gardasil 9, what are the real-world hurdles? Moving beyond the science, what are the most immediate and complex logistical, economic, ethical, and political obstacles preventing us from shifting the paradigm? Moving beyond the current, often patchy, system of screening towards making prophylactic HPV vaccination the mandatory universal standard of care globally.
What stands between our current reality and the potential elimination of this cancer? Cost, vaccine delivery infrastructure, cold chain storage, training personnel, public acceptance and addressing vaccine hesitancy, political will.
That's the challenge. It's less about the science now and more about implementation, equity, and commitment on a global scale. Something to think about.
Indeed. That's the execution challenge we leave with you. Thank you for joining us for the deep dive.